Welcome to Mercy Weight Loss Solutions. My name is Dr. Ursula McMillan. In the next several minutes, I will go over what the program entails. Our program is a comprehensive weight loss program for the surgical and or medical management of obesity. Our team includes 2 bariatric surgeons. I am one of the bariatric surgeons, and Dr. Viriato Fiallo is a second bariatric surgeon. There are 2 bariatricians. There are 2 dietitians or nutritionists, and a host of nurses and physician's assistants that have also assisted us. In the next several minutes, I will go over what the program entails. There are 2 arms of the program. There is a medical weight loss program portion of the program. There is also a surgical portion of the program, and we will go over who meets criteria for each of these arms of the program. Some of the objectives are to define obesity and its effects on society and healthcare, talk about weight loss surgery in particular, discuss some of the medical management versus surgical research, and determine why we use surgery as a modality most times, and evaluate the different types of weight loss surgery that are available. Obesity is an epidemic that is becoming more and more problematic. There is 35.7% of the United States adults are considered obese. There is about 68.8% of American adults who are either overweight or obese. Most of those adults are women. Given that, this is a significant problem, and this is why the insurance companies are actually paying for this weight loss management. One of the problems recently are that there are significant amount of children, about 70% of children and adolescents are obese and are developing some of the obesity-related comorbidities that were previously only adult problems. There's a significant amount of mortality and morbidity associated with obesity. BMI of 30 to 35 decreases a person's life expectancy by 2 to 4 years. Having a BMI of greater than 40 decreases the life expectancy by at least 10 years. This is related to several of the obesity-related medical problems that come along with being overweight, such as heart disease, high blood pressure, diabetes, high cholesterol, sleep apnea, as well as increased incidence of certain cancers. There are several causes for obesity. The direct causes are not completely ascertained as of yet. Some of the causes that we have attributed to, some of the causes that are attributed to obesity are genetic components, more metabolic component, social, economic components, period. Obesity has cost the healthcare system a significant amount of money, and the insurance companies are often paying for these medical weight loss as well as surgical weight loss, as they decrease the amount of money that the government is having to spend on some of these obesity-related comorbidities. The annual cost is about $270 billion currently. Some of the causes of obesity are related to some of the genes that you may have inherited from your parents, how well your body turns food into energy, some of your habits, your eating habits, whether you eat a diet that is higher in carbohydrates or whether you eat a diet that is higher in fiber and protein, and some of the exercise habits that you may have. Some of the surroundings and environment, the types of commercials that are on television increase the need and want for certain people to eat a lot of meals on the go, and that has also increased the obesity rate recently. Psychological factors have also played a significant role. People are feeling depressed and have low self-esteem, and often do not want to often do not want to be as active as they possibly could, and they would like to stay out of social environments secondary to those feelings of depression, low self-esteem. Some of the hormones that are associated with obesity are ghrelin, which is a significant hunger hormone, which we will discuss later when we talk about the laparoscopic sleeve gastrectomy as a surgical modality. Leptin is how leptin helps to determine how much fat your body stores. Insulin determines the metabolism of the fat that is stored in your body. And another hormone is called PYY, which is a hormone to help your body determine how full it is. We will not discuss many of these hormones in detail, but ghrelin will definitely be discussed in detail when we talk about the sleeve gastrectomy. So there are some cue and reward systems that are in play currently with most obese patients. Our goal is to change some of those cue and reward and routine feedback systems. Currently, a significant amount of people will eat fast foods such as McDonald's, and those foods taste very good. They send a signal to the brain where there is a certain feeling of happiness after eating those foods. Shortly thereafter, the patients may not feel very well after consuming those calories, and they feel depressed about gaining the weight. We would like to change those cue reward routine systems to increasing the amount of healthy foods that we're eating, increasing the amount of exercise, or increasing the amount of exercise that we can achieve in our daily routines, so that we are becoming healthier people and losing more weight and becoming and losing some of the medical problems that we have previously had. So that is the goal, to change some of those cue routine reward systems to healthier cue routine rewards. There is a model called the body mass index. It is a calculation to determine the height to weight ratio of an individual. It allows providers to talk to one another about the health of a particular patient. We talk about body mass index as it relates to a individual's ability to be a candidate for weight loss surgery. Usually a person is a candidate for weight loss surgery with a BMI of 40 if they have no obesity-related comorbidities such as high blood pressure, diabetes, hypercholesterolemia, or high cholesterol, sleep apnea, or heart disease. If a person has any of these medical problems that were just listed, they are a candidate for weight loss surgery at a lower BMI of 35. The body mass index can be calculated by multiplying the weight in pounds by 703 and dividing the person's height in inches squared. The obesity classification system: a person is considered underweight at a BMI of 19. Normal weight is considered at a BMI of 19 to 24.9. Overweight is 25 to 29.9. Class 1 obesity is 30 to 34.5, and Class 2 obesity is 35 to 39.9, and morbid obesity is considered greater than 40. There is a additional classification which is considered super obese, and that is a BMI greater than 50. We've talked about some of the comorbidities that are related to obesity. Some of the additional ones outside of high blood pressure, diabetes, sleep apnea, heart disease also include reflux, which is not usually uh, a medical condition that allows a person to have surgery at a lower BMI. Depression and gallbladder disease also happen with patients who are overweight or obese, but are not criteria for weight loss surgery at a lower BMI. Some of the additional comorbidities are rashes underneath skin folds, arthritis in the joints, urinary stress incontinence, which is leakage of urine secondary to a significant amount of abdominal pressure from extra fat or skin on the abdomen, having fertility problems, decreased ability to get pregnant for some women, or having lower sperm counts for men, and certain types of cancers are increased, such as breast cancer and prostate cancer. We've talked about some of the psychosocial implications of obesity. People have lower self-esteem and low confidence. A lot of times there is reduced employability, and oftentimes these patients are paid less because of the reduced employability. They have decreased opportunities for promotions. Also, there is often decreased libido or sex drive secondary to the derangement in hormones, sex hormones that the patient may experience. There's also social isolation, which is related to the small size of seating in social atmospheres such as movie theaters, airplanes, and amusement park rides. In addition to surgical management, there are several non-surgical interventions that have been investigated. Many of these non-surgical methods do not work well on the morbid obese patient. Some of these non-surgical interventions have been diets, which are Jenny Craig diets, Weight Watchers, OptiFast, Medifast. Oftentimes, these medications or diets alone do not achieve long-term weight loss in obese or morbidly obese patients. They may, however, have some role in patients who have already undergone weight loss surgery and have had some recidivism, which is increase in weight after having weight loss surgery. Sometimes these patients may use these modalities in order to get back on track, to start eating healthy again, and to become more active. And they have been helpful in those instances. There are also several medications that are on the market, which are appetite suppressants and combination of medications that have also been helpful for patients who either do not meet criteria for weight loss surgery or who have had weight loss surgery and have started to gain some of the weight back. Those medications do help those patients who don't need to lose a significant amount of weight or who need to lose a little bit of weight after having had weight loss surgery. These medications, however, do not achieve long-term success and do not achieve very large amounts of weight loss for patients who are significantly obese or morbidly obese. We will now discuss the surgical management of obesity. There are two groundbreaking studies that showed that bariatric surgery was superior to medical management. These two studies came out in March of 2012, and they looked at the medical management specifically of obesity, which is increasing medications, increasing activity, and also these patients were placed on medically monitored diets with nutritionists. The other arm of the patients underwent bariatric surgery, which were twofold. One was a gastric bypass, and the other arm was a sleeve gastrectomy. These studies both showed that patients who underwent medical management, although they may have lost weight, their diabetes was not well controlled, and their blood sugars were higher than they had been previously. Patients who underwent weight loss surgery, either sleeve gastrectomy or gastric bypass, had complete resolution of their diabetes in most instances, and if the diabetes was not completely resolved, was significantly improved prior to surgery. These two studies showed that surgical weight loss is superior to medical weight loss, And these are very helpful in discussing uh, the benefits of weight loss surgery with patients, primary care physicians, and also discussing the benefits with patients, potential patients. There are several surgical management options for weight loss. There is a gastric bypass. It used to be done as an open gastric bypass when it was started in the 1950s to 1960s. In most instances, now we perform these surgeries through very small incisions and are performed laparoscopically. There is a adjustable gastric banding, or we also consider it a lap band. We, however, do not perform many of these surgeries anymore, as they have a significant amount of complications associated with them, and the weight loss is considered to be very poor. The most commonly performed procedure is called the laparoscopic sleeve gastrectomy, and is performed about 90 to 95% of the time. There is also a duodenal switch, which is a more complex surgical method for weight loss, and is often tried after the patient has undergone one of the previous methods. Usually the sleeve gastrectomy can be converted to a duodenal switch if the patient needs to lose a significant amount of weight. The gastric bypass employs two methods in order to lose weight. There is a malabsorptive method where the bowel is rerouted so that there is some food that the patient eats that is not digested but is not absorbed. The other component of weight loss is restrictive. The stomach is made very small, the size of a ping pong glass or a ping pong ball or a shot glass. So those two methods allow the patient to lose a significant amount of weight. The weight loss is somewhere between 60 and 80% of the excess weight loss. There are several possible complications. There are several areas where we staple the stomach or the small intestine in order to create the procedure. Those areas are potential areas for leak, which mean the fluid from inside the stomach or the small intestine may leak out into the surrounding tissues and can make the patient very sick. We are able to test some of those areas at the time of surgery, which is the proximal area at the level of the stomach and the small intestine connection. If we are able to determine whether there's a leak at that particular area, all the other areas that are stapled and sutured at the time of surgery are not able to be completely tested. The operation is a very safe operation. However, we have seen a significant amount of patients who have gained a significant amount of the weight back, if not all of the weight back, somewhere between 3 and 7 years. One of the problems is that the connection between the stomach and the small intestine may stretch significantly, so the food does not stop in the stomach any longer and empties rapidly into the small intestine, and those patients are hungry very quickly and start to consume larger amounts of food. If those patients have not included exercise or increased activity in their daily life, those patients will often gain the weight back. If they have not stuck to a strict diet after surgery, which includes a higher protein, higher fiber diet, lower carbohydrate diet, those patients will often gain the weight back. Because of this problem with weight gain after gastric bypass, we have gotten away from doing a significant amount of these gastric bypasses. These gastric bypasses, however, are very helpful in managing patients who have very poorly controlled diabetes and are on both medications by mouth as well as insulin and have poorly controlled blood sugars. For those patients, they are benefited by having a gastric bypass because oftentimes those patients will go home off their diabetic medications and their diabetes will often go into remission. In addition to having a possibility of leak at the time of surgery, patients can develop bowel obstructions down the line after having this gastric bypass. They can also develop a phenomenon called gastric dumping, which is the inability of the small intestine to handle sugars. The patient may be able to have sugar substitutes, but will never be able to eat real sugar again. This is a deterrent most times for poor diets for these gastric bypass patients. There is also malnutrition that's associated with this procedure. The patient may lose too much weight in the beginning, and it's very important for the patient to follow up with their provider on a regular basis. There may be also a significant amount of vitamin deficiencies, which is very important for the patient to follow up with their surgeon to prevent any of these vitamin deficiencies. There are vitamins that the patient will have to take for life, and it's very important for the patient to follow up with their surgeon on a regular basis. Some of the benefits of gastric bypass are large scale weight loss. We discussed 60 to 80% of excess weight can be achieved. There is improved health and well-being. This often produces remission of diabetes and other obesity-related comorbidities such as high blood pressure, high cholesterol, sleep apnea. Some of the expected outcomes for gastric bypass surgery, we talked about the excess loss of body weight. There are chronic vitamin use that is required, regular visits with your surgeon. The weight loss is very rapid, and most people will lose all of the weight that they need to lose somewhere between 6 months and a year. Sometimes there will be excess weight loss that can happen beyond a year. Due to the rapid amount of weight loss in a short amount of time, there is excess skin that may be a problem, and sometimes a consultation with a plastic surgeon may be required. We discussed dumping syndrome. Patients will need to eat smaller food portions, and there is a possibility for nausea and vomiting, as a patient may need to learn how to eat all over again, as their stomach is significantly smaller than it was previously. There are complications, as with any kind of surgery. There are specific complications with weight loss surgery. There is a possibility of death if a patient develops blood clots to the legs that may travel to the lungs. So it's very important for the patient to walk around very early on after having weight loss surgery. We encourage people to walk the night of surgery. If patients are unable to walk following surgery, they may go home on blood thinners for a few weeks. There is a possibility of significant illness if the patient develops a leak after gastric bypass period. It's very important to be in contact with your surgeon if you feel that you are not improving clinically after weight loss surgery. If you're feeling worse and not better, it's very important to give a call to your surgeon. There are a possibility of an infection at the incision sites, possibility of hernias, either intra-abdominal hernias, which may cause bowel obstructions, or also possibility of hernias at any of the laparoscopic ports that we may use in order to do the surgery. This is a gastric band. Again, we don't perform these procedures. We may modify some of the ports for some of the patients who already have bands, but we do not perform laparoscopic gastric band surgery. Two of the main possible complications are gastric band slippage and gastric band erosion. Gastric band slippage often happens from a significant amount of vomiting after having the surgery. Patients have an altered type of eating and often feel that food is getting stuck at the level of the gastric band. They often vomit so that the stomach rolls up through where the band is supposed to be, and the band ends up at the middle of the stomach and creates a waist on the stomach. This creates a significant amount of heartburn and discomfort in the upper portion of the abdomen. The way to determine whether someone has a gastric band slippage is either to do a endoscopy, which is what I usually perform and I recommend, or to do an upper GI study. If the band is slipped, I usually will convert a patient to a sleeve gastrectomy for long-term management of their weight loss. Sometimes these bands can be replaced, but a lot of times people are not losing the amount of weight that they need to even after replacing the band. The weight loss is very poor. It's about 20% of the person's excess weight. There are a significant amount of patients that we have seen that have either not lost any weight or have gained a significant amount of weight more than they were when they had the weight loss procedure. The other complication is called gastric band erosion, which comes from a significant amount of pressure on the stomach, and patients may vomit a significant amount of time, causing more pressure on the stomach, or either use anti-inflammatory medications such as Motrin, Aleve, ibuprofen. Those medications can cause ulcers and lead to the band burrowing a hole into the stomach and ending on the inside up of the stomach as opposed to the outside of the stomach, which requires an operation where we remove the band and place drains into the hole in the stomach closes. Given these complications and the poor weight loss, we have gotten away from placing gastric bands. The next procedure is a laparoscopic sleeve gastrectomy, and it is performed about 90 to 95% of the time. I believe it's the best procedure that we have to offer currently for weight loss. During the procedure, we remove about 2/3 of the stomach, and you are left with a sleeve of stomach that is about 1/3 of the amount of the original stomach. When we remove the portion of the stomach, the top part of the stomach, called the fundus, creates a hunger hormone called ghrelin. When we remove that portion of the stomach, a patient is significantly less hungry and may not be very hungry at all. This has helped significantly with weight loss, as the patient has less desire to eat as much as they were before. In addition, we have reduced the size of the stomach, which is a restrictive procedure and allows the patient to eat a significantly less food than they were previously. The pylorus is a muscle between the stomach and the small intestine that also helps with keeping the food in the stomach for a long period of time before it empties. It is very important, however, with any of these procedures to make sure that you are consuming a diet that is healthy for you, which is a higher protein, higher fiber diet, and lower carbohydrate. Patients who eat a significant amount of carbohydrates and junk food will not do well from any of these procedures, as this food will turn into a liquid before it enters the stomach, and it will empty quickly from the stomach, allowing the patient to consume a larger amount of food than they were previously. This will either hinder their weight loss or allow them to gain more weight than they were when they began. Very important to realize that this is a tool. These procedures are tools, and there is work that the patient must do, which is increasing activity and also making sure that they're eating a balanced, higher protein, higher fiber diet. Some of the complications with the gastric sleeve, as you can see, there is a staple line. There is a possibility from leak from this one staple line. We do test this in the operating room when we do the procedure to make sure that there is no leak at the time of surgery. Each patient for any of these weight loss procedures is on a stage progression of the diet back up to regular. They are on a liquid diet for about 10 days, puree diet, then soft regular diet, then regular diet. It takes about 6 weeks before the patient is back on regular food. If the patient goes home and decides they are going to consume foods before they should, they can develop a leak at home, which could be very detrimental. Very important to follow the postoperative diet that is prescribed at the time of surgery. One of the other possible complications is short-term heartburn. Sometimes patients will have a reflux feeling after surgery. Usually this is related to the smaller size of the stomach and also to some edema that is associated with the surgery. This usually will go away on its own, and it's usually self-limited. If the patient continues to have some heartburn symptoms, we can also prescribe antacid medications. This procedure is also performed laparoscopically through small incisions. Patients usually will stay in the hospital overnight and usually will go home the next day. For gastric bypass, patients usually stay 1 to 2 nights in the hospital, and they are on the same progression of the diet back to regular as the sleeve gastrectomy patients. In terms of follow-up, we usually see patients 2 weeks after surgery, and then at least once every 3 months up until a year's time frame, and then at least once a year after that. Patients who have gastric sleeves do not have significant malnutrition, do not have vitamin deficiencies. Patients will be asked to take a multivitamin and B12 with a sleeve gastrectomy. With gastric bypass, patients will be asked to take a multivitamin, B12, calcium, and sometimes vitamin D, period. We will also be checking those labs to make sure that the patients do not have derangements of those vitamins for any of the patients who have gastric bypass or sleeve gastrectomy. The sleeve gastrectomy is a purely restrictive procedure. There is no rerouting of the small intestine, so all of the food that you may consume will be absorbed. That is why it is so important to make sure that you're eating a healthy diet most of the time. Again, there is about 2/3 or up to 80% of the stomach that can be removed with the sleeve gastrectomy. There is significant hunger control with removal of the hunger hormone ghrelin, and this is not removed with any other weight loss procedure that we perform. The weight loss is excellent. It is a tool, however, and there is a benefit to adding some formalized exercise after having any of these procedures. Some of the risks of sleeve gastrectomy, we talked about leak. There is a possibility of obstruction if there is significant scar tissue that forms at any portion of the sleeve gastrectomy. This can be managed usually with endoscopy and balloon dilation. There may be some gastroesophageal reflux. There may be some vomiting with any weight loss procedure, as a patient is going to have to learn how to eat all over again with a smaller stomach. There's a possibility of bleeding as well from any of the staple line or any of these port sites. And as always, there is a possibility of blood clots like gastric bypass. It's very important to walk and be mildly active after surgery. And there is always a possibility that we may send a patient home on blood thinners if they are unable to walk or be active. This is a duodenal switch, which often can be performed after a patient has had a gastric sleeve. There is a significant amount of bypassing of the small intestine, and this is often only done in patients who are very, very compliant patients. There are a significant amount of possible complications, such as severe malnutrition that can occur with this procedure, as there is not very much food that is absorbed or vitamins that are absorbed. If a patient has a significant amount of weight that they need to lose, or they have gained a significant amount of weight back after having a sleeve gastrectomy, after consultation with a bariatric surgeon and also discussion with our bariatric team, we will determine who is a candidate for this and whether that patient is very compliant and whether they are healthy enough to undergo this procedure. If we need to, this is a revisional surgery and is usually not performed as the first operation. The postoperative course includes 1 to 2 days usually in the hospital. There is a stage progression of the diet, which we discussed, and it usually takes 6 weeks to get back to regular food. There is a requirement for regular follow-up with your surgeon and also possibly with the dietitian, so that we can assure that the patient is getting the most from their weight loss surgery. There is occasional lab work to check for vitamin levels, and there is the importance of continuing on a higher protein, higher fiber, lower carbohydrate diet and adding some formalized exercise. It is very important to attend support groups if you can. The patients who continue to attend support groups even after undergoing weight loss surgery have been seen to have done better in terms of keeping their weight off long term. I cannot stress enough how important it is to attend support groups and add some formalized exercise and see the dietitian if you are getting off track in terms of your eating. Some of the contraindications to bariatric surgery are a physical health that prohibits having surgery, such as a heart condition or lung condition that prohibits having successful surgery. Inflammatory bowel disease is usually a relative contraindication. Severe liver or kidney disease that may prevent having surgery as well. Pregnancy, addiction to alcohol and drugs. Patients will usually have to show that they have been clean from alcohol and drug use somewhere between 6 months and 1 year. The patient must be a non-smoker, and we do check blood work to determine whether they are a non-smoker. Patient must be nicotine-free at the time we submit their information to the insurance company for approval for any of these weight loss surgeries. Chronic steroid use is also a relative contraindication, as it decreases healing and can increase the risk of postoperative complications such as leak. determine this on a case-by-case basis, but chronic steroid use and large amounts of steroids are a relative contraindication. Autoimmune or connective tissue disease may also be a contraindication, and patients must be cleared by a psychologist or psychiatrist and be deemed psychologically healthy in order to undergo weight loss surgery. The medical weight loss component of the program is usually discussed and is a tailored program specific to that patient, which may include appetite suppressant medications, dietary counseling, as well as some meal replacements. The patient will meet with the bariatrician, who is the medical weight loss doctor, and determine what would be best for that patient. There is usually a combination of the modalities we discussed. If this is something that you are interested in, you are not interested in weight loss surgery, or you do not meet criteria for weight loss surgery, or if you have already had a gastric bypass and you need to lose some additional weight, this is often where we will refer you to the medical bariatrician. If you are interested in weight loss surgery and you meet criteria, please don't hesitate to give us a call. Or if you are interested in medical weight loss, please don't hesitate to give us a call. Thank you for your time.